First of all, I would like to thank the organizing and the scientific committee of this conference for the great organization, and also for choosing the titles of the topics that we are going to present to give you a complete, complete look for pain, how to diagnose it, how to classify it, how to assess it, how to treat it, and I hope by the end of the second day you will be able to give the proper management that we are all aiming to our patients. Helen Keller, she said, alone we can do so little, together we can do so much. And this is what we are doing in palliative care. We are working, as Dr. Stanley mentioned a while ago, through a multidisciplinary team. Our team usually consists of the palliative care specialist or consultant, in addition to the other physician of house officers or registrars, also the nurse who's specialized in palliative care. We have the spiritual counselor, we have the pharmacist, we have the health educator, we have the social worker, the clinical psychologist, the occupational therapist, the physiotherapist. We are a complete team. We can give what we call it as the holistic care for the patient. And our aim, of course, is to give the patient a good quality of life. Before I go to the classification of pain, I just like to remind you about the definition of pain. As you know, it is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. How about cancer pain? Cancer pain is the most prevalent symptom with patients suffers from oncological disease. They said that about 40% will have 4 or more pains. That means I will mention later on, different types of pain. Each patient, those 40% will have more than one type, and it might reach up to 4 types of pain. And it is our duty to relieve their pain. As you know, cancer pain is the most feared and burdensome symptom the oncology patient might suffer from. Or any patient, pain is miserable. And of course, pain is the chief complaint will bring the patient to the emergency room or disturb the patient's life. It's not only the patient, their caregivers also are disturbed. Just imagine you have a member of your family or your friend suffers from pain. And of course, cancer pain has many reasons. It can be multicausal, multifocal, and dynamic also. Let's go to cancer pain. Is there a special definition for cancer pain? They said cancer pain doesn't have a specific definition. Cancer pain was defined as pain in patient caused by neoplastic disease itself and or diagnostic procedures or treatments like taking biopsy, inserting a stent, chemotherapy can cause, radiotherapy can cause pain, and sometimes surgical intervention, of course, can cause pain. Of course, we are not oncologists, with all regard to our colleagues, the oncologists, but we need to have a background of oncology and the treatment of oncology because we are giving a treatment which might help the patient or prevent them from suffering of pain and other symptoms. Cancer patients who have advanced cancer disease or on aggressive cancer treatment and even the long-term survivors and even those in remission suffer from pain. And also other symptoms. There are a long list of symptoms cancer patient suffers from, like fatigue, depression, dyspnea, sleep disturbance, nausea, constipation. There are a long list. But can you imagine that oncology patients or cancer patients, they might suffer from 12 symptoms in one time. Most of the patients, they suffer from 12 symptoms at one time during their disease process. On top of those symptoms is pain. So let's see the patients with advanced malignancy. They often have pain as their chief complaint, as I said a while ago, but let's see how much is percentage. The patient will, in their early stages of their cancer disease, about 20 to 50% they suffer from pain. And 95% or 55 to 95% in the later stages of their diagnosis, they suffer from pain. Those 95% usually we call them the terminally ill patients. 60 to 80% of the patients, they have pain related to their tumor. And the most common pain is due to bone metastasis. 20 to 30%, it is treatment-related pain due to chemotherapy, for example. 10 to 15% of the patient, they suffer from pain unrelated to cancer. I will not consider here the psychological pain of the patient because psychological pain is an important type of pain cancer patients suffer from. But of course, the patient, they can have other comorbidities, like for example, diabetes, which can be painful. Simple symptoms, constipation can cause pain to the patient. You can see here the key symptoms in palliative care. These are the symptoms I mentioned a while ago that cancer patients might suffer from. They can suffer from depression, which is very common with cancer patients, delirium, anxiety, nausea, vomiting, dysphagia, dyspnea, fatigue. They might have bed sores, which are painful, of course. They can have bone pain, they can have constipation, anorexia, xerostomia, I mentioned anxiety a while ago. And also sometimes our treatment can cause pain. As you know, opioids can cause lots of symptoms, side effects they have, like constipation and nausea and vomiting. So as long as you describe to the patient opioids, you need to keep in your mind their side effects, because those side effects might worsen the symptoms, the pain of the patient. And of course, we want to relieve their symptoms. So we prescribe opioid, we need to give the patient laxatives, we need to give the patient antiemetics, and all of the other supportive treatment. How about the taxonomy of pain in cancer patients? Clinically, it is useful to determine both the etiology and inferred pathophysiology in the assessment of the pain complaint, as this may suggest the use of specific therapy. If we don't know the type of the pain the patient suffers from, that means we won't be able to treat the patient properly. So which type of analgesics you will choose if you don't know the type of the pain? We need to know the type to give the proper treatment and at the end to relieve the suffering of the patient. So classification of cancer pain may be based on the anatomy, by the site of the pain, by the body system. Is it the CNS? Is it the GIT? Is it the urinary system? Also, we can classify it temporally. Is it acute, chronic? It depends on the timing of the pain. Also to the severity. You saw a while ago the pain assessment tool. It can be mild, moderate, and severe. Due to the etiology, and this one you need to work on it. Is it due to the effect of the tumor itself? Is it due to the treatment or whatsoever our reason? It is very important to know the pathophysiology of the pain. Your treatment will be helped a lot by knowing the pathophysiology of the pain. And of course, there is something called defined pain syndrome. You will find it out when I continue with my presentation. So this is a good look for the classification of pain. Pain can be classified temporally or according to the duration to acute and chronic pain. And pain can be classified by its nature. It can be nociceptive pain, which can be somatic or visceral pain, and it can be non-nociceptive pain, which is neuropathic and sympathetic types of pain. We will discuss all of these types now. So in addition to that, as I mentioned, nociceptive pain and somatic, which could be somatic or visceral pain, and neuropathic pain. There is what we call it as psychogenic pain, and there is what is called as idiopathic pain, and there is also the breakthrough pain. So this is the way we classify the pain according to its nature. There is another type of pain, I didn't mention it a while ago, which is the mixed type. The patient can have both nociceptive and neuropathic pain at one time. Nociceptive somatic pain, sustained predominantly by tissue injury or inflammation, the patient will come with sharp, aching, stabbing, throbbing, or pressure-like pain. While the visceral nociceptive pain, it is usually poorly localized and described as crampy pain, example like a patient with intestinal obstruction, or as aching and stabbing, like the pain secondary to splenomegaly or hepatomegaly. How about neuropathic pain, which is more difficult to treat than the nociceptive pain? It is sustained by normal somatosensory processing in the peripheral nervous system or the central nervous system, typically described as burning, shock-like, and electrical-like pain. It might be paroxysmal in nature. On physical examination, patient may have allodynia, which is pain caused by non-painful stimuli. So even touch can cause pain to the patient. And it can be hyperalgesia type of pain, which means increased perception of painful stimuli. For example, if you want to insert the needle to the patient or take blood, the patient will scream of pain. Of course, it is painful, but not to that extreme. Neuropathic pain sustained by abnormal somatosensory processing in the peripheral and the central nervous system. Sorry, this one is deleted. Typically, it is described, as I said, burning and shock-like. It can be due to many causes, but some of the most common neuropathic pain causes: alcoholism can cause neuropathic pain, amputation, phantom pain, back and leg and hip problems can cause pain, like with bone metastasis. Chemotherapy can cause pain. As I said, we need to know a little of our oncology treatment given to our patients, and I think the platin group, carboplatin and the others, can cause neuropathic pain. Diabetes mellitus, as you know, can cause peripheral neuropathy. AIDS can cause neuropathic pain. Shingles, post-herpetic neuralgia, and I think most of you know about it. Spinal surgery can cause pain also, neuropathic type. On physical examination, patient may have, as I said, allodynia and hyperalgesia. Some observational studies shows that neuropathic pain is more likely to be, the patients with neuropathic pain, they are most likely to be on opioids at higher doses because it is very hard to control their pain. And actually, the treatment for their pain is not opioids. So you will keep on increasing the opioids, and the patient will not be affected. The symptom will not be relieved. They, of course, use greater types of adjuvant treatment, and of course, it has a poorer pain outcome because it's really hard to control this type of pain. And you will need, of course, longer time to titrate your analgesia with those patients. So presence of neuropathic pain will signal the need for multimodal analgesia. So we don't give the patients opioids only. We need to use the help of the adjuvant treatment, which are the proper treatments for neuropathic pain, simply like dexamethasone, like tricyclic antidepressants, and some anticonvulsant treatment can help greatly in controlling the neuropathic pain. And remember, there is no such thing as a neuropathic drug. There is nothing specific called neuropathic drug for neuropathic pain. No, all of these are adjuvant treatment. It happened that they knew by using these drugs, they have an effect on controlling neuropathic pain. Patient can be informed that pain control might take longer time. Be frank with your patient, tell them and discuss with them the treatment plan, and tell them that this type of pain might take longer time, might need more treatments to control it, but it will take some time. And tell them also that you will always be around to help them for their pain. How about the psychogenic type of pain? It refers to pain that is believed to be sustained predominantly by psychological factors. And what more than cancer can cause psychological pain to the patients and to their families and caregivers? It is common in cancer patients and unfortunately usually missed or underdiagnosed. We ignore the patient psychology actually in treating their pain. Pain doesn't mean only the physiological symptoms, it can be psychological symptoms, and this is more difficult to control and to diagnose than the physiological pain. How about idiopathic pain? There is something, like there is fever of unknown origin. Is there a pain without a reason? It can be. In the absence of evidence sufficient to label pain as either nociceptive or neuropathic, we may use the term idiopathic. But of course, don't jump to diagnose the patient with idiopathic pain before working up hardly to find the real reason for that pain. In patients with cancer, this term should lead to additional workup and search for an underlying etiology and pathophysiology. How about breakthrough pain? It is a sudden and transient, clinically significant worsening of the persistent pain baseline that is controlled by analgesic regimen. A typical episode may peak in as little as 3 minutes, and it might extend up to 30 minutes. Up to 86% of patients with chronic or persistent pain, they experience what we call it as breakthrough pain. So always we need to give the patient a breakthrough analgesia. Never ever prescribe a treatment to control the baseline pain or the chronic pain without a backup, without a rescue treatment for the breakthrough pain. Breakthrough pain is associated with functional impairment and psychological distress. It is a catastrophe for the patient and for the caregiver. Breakthrough pain is different from persistent pain and requires different treatment. Have a look in here. This is the background pain, the baseline pain, and it will be controlled by opioids, of course. It can be these long-acting opioids. The patient can have 2 types of breakthrough pain. One of those is the gradual onset breakthrough pain, and the other one is the rapid onset breakthrough pain. These 2 types of pain can be, we call it like breakthrough pain, and for that we need to give the patient the rescue treatment, which we call it rapid onset opioids, which are the short-acting opioids. Why we choose this type of opioids? Because the onset of action is faster, and also it ends in short time, which will cover this, as we said, 3 to 30 minutes pain period. How about the nomenclature related to breakthrough pain? There are different types of the breakthrough pain. Breakthrough pain can be incidental breakthrough pain. For example, the patient will tell you, I'm okay, I'm controlled with my regular long-acting opioids or whatever analgesic, but when I move or when I walk, I have pain. So this is what we call it as incidental breakthrough pain. It is more common with patients with bone metastasis, and of course it is predictive because the patient will know the trigger which might cause the pain. So we need to tell the patient that we will give you the breakthrough treatment. You need to take that treatment at least 15 minutes before you start this activity, before walking, before taking the bath, or before sometimes we need to tell the family, before moving the patient on the bed, turning the patient. We need to give it at least 15 minutes ahead, so it will have its action, and so the patient will move free of pain. How about the episodic pain? This is what I mentioned a while ago, like a gradual onset or rapid onset pain. It is a transient pain that occurs with increased intensity above that of the baseline chronic pain. Usually it is visceral pain and it is not predictive. And also for that we need to give the patient the proper dose of the rescue treatment. And the most important type is the end of dose failure pain. This is called as also type of breakthrough pain. It occurs at the end of the dosing interval of a fixed schedule analgesic and relates to the decline in effective blood level of the drug. The analgesic dose at this point need to be changed, and you need to review your treatment and increase the regular treatment. It means that you are giving the treatment, but it is in a smaller dose for that pain, for that intensity of pain. And it is, I think, very important to calculate the exact dose which the patient needs to control the chronic pain or the baseline pain. Also, that rule also we need to follow it with the breakthrough analgesia. You shouldn't give the dose which is not calculated well according to the baseline treatment. Let's go to the physiological effect of pain on the patient. As you know, pain can increase the catabolic demand of the patient. So the patient will suffer from poor wound healing, weakness, muscle breakdown. This is a very bad complication of poor control of the patient's pain. Of course, the patient will suffer from decreased limb movement, which will increase the risk of DVT and pulmonary embolism and all the other types of coagulopathic diseases. It has an effect on the respiratory system. It causes shallow breathing, tachypnea, cough, depression, increasing risk of pneumonia and atelectasis as a result. It will increase the sodium and water retention because the patient is immobile. It will also affect the kidney. It will decrease the gastrointestinal mobility of the patient. It will cause tachycardia and elevated blood pressure. This is, in summary, the physiological effects. How about the psychological effect of pain? It will cause negative emotions of the patient. The patient will suffer from anxiety and depression. It reach up to major depression. Some patients, they kill themselves because of the pain. And this is our mistake because we need to assist them quiet well and to give them the proper treatment. Pain can cause sleep deprivation. How many of us suffered from headache which prevent us from sleep? Just think about those poor patients with cancer. And also it causes existential suffering, for sure, and also it causes family anxiety. Always with pain, it is not only the patient, it's also their caregivers. Let's talk now about the cancer pain syndrome. In general, syndrome is a temporal and qualitative conversion of symptoms and signs which conforms to a recognized pattern. It is associated with distinct etiologies, pathophysiologies, and prognostic and therapeutic implications. For cancer patients, this pain syndrome related to the tumor involvement, as we said a while ago. Pain syndrome associated with cancer therapy also. Pain unrelated to cancer therapy, it might be related to other comorbidities. And also, syndrome also can be in generalized pain in dying cancer patients. How about the temporal classification of the cancer pain syndrome? It can be classified as acute pain, chronic pain, and the breakthrough pain. We mentioned the breakthrough a while ago. Let's go to the acute cancer pain. It is defined by a recent onset and natural history characterized by being transient pain, may or may not be associated with overt pain behavior, usually caused by diagnostic or therapeutic intervention. So there will be a reason and it will be a treatable reason. There is a long list of acute cancer pain. It can be, like I said, diagnostic intervention, post-operative pain, in other therapeutic interventions, analgesic techniques associated with chemotherapy, with radiotherapy, with even hormonal therapy, associated also with immunotherapy, and also associated with infection, because all of these are treatable conditions. While chronic pain, it persists. Some people, they said 3 months, and some people, they said any pain exceeds 1 month, we can call it as chronic pain. Beyond the usual course of an acute illness or injury, most commonly due to direct effect of the tumor, and the other causes can be the cancer therapy and pathology unrelated to either cancer or its treatment. There is a long list for the chronic pain. It can be related to tumor itself, to bone pain syndrome, headache and facial pain, tumor involvement of the peripheral nervous system, visceral pain syndrome like the patient with NET, somatic soft tissue pain syndrome, paraneoplastic pain, pain associated with cancer therapy, and so on. Just I want you to remember there is a type of pain, we call it cancer pain emergency. Don't forget, we can consider the cancer pain emergency causes for cancer pain as another type of pain. Why I mention that? Because those patients will need an urgent action. Like the patient who comes with bone metastasis in their spine, they need an urgent action to help them, even though that we are not oncologists, but those patients will need urgent radiation therapy. So don't hesitate to take a consultation from the radiation therapist. Also, withdrawal symptoms is another type of pain, bone metastasis and impending fracture. Okay, I'll go. Just I want to remind you that your prescription for pain for your patient should include some tablets for courage and hope and love. Just I want to discuss with you this case, and I would like you to help me in answering few questions. There is a 50-year-old man who, with squamous cell lung cancer, developed right-sided pelvic pain in the region of non-pelvic metastasis. So we know that this patient has a pelvic metastasis, and which causes pain. He describes dull aching pain rated 8/10. So this pain is considered as severe pain, of course, in the lateral pelvis, and sharp shooting pain that radiates down the right leg. So what type of pain is this? I wish if I can hear from the ladies' side. Neuropathic, right? Exactly. The pain limits mobility and awakens him from sleep. It is severe pain, of course. He has no focal motor or sensory deficits, and X-ray shows large lytic metastasis in the lateral pelvis. He is referred to the radiation oncologist and he received radiation therapy. The patient has been taking morphine sulfate, immediate release, 30 milligrams every 4 hours. It worked well at that time. Currently, he takes this dose every 4 hours, but his pain only decreases from 8 to 10 to 6 to 10 for 1 to 2 hours at best. So what does that mean? What do we call this?
End of dose failure.
End of dose failure, exactly. You are concentrating. So we classified that type of pain, and just for all of us to remind ourselves, do you know how soon should the analgesia begin from the radiation therapy? I will not ask Dr. Fouda. It starts about 3 weeks, so you need to give the patient a proper treatment in the first 3 weeks. Don't think that it will be an immediate action for radiation therapy. And how about the maximal benefit from radiation therapy? It will be about 6 weeks after the radiation therapy. So if you decide to use an antidepressant as an adjuvant, what drug and dose would you start with this patient? Pregabalin can be used, yes. What other types also? You know the doses for pregabalin, but they will talk later on about the doses. Do you think there is other adjuvant drug other than the neuropathic, very well-known drug for neuropathic pain, like antidepressants and pregabalin, anticonvulsants? Yes, steroids is a very good option, the magic treatment. And just I'd like to mention that psychological support is very important, and before that, you need to sit with your patient, explain your plan of management, discuss with the patient what fears him, what makes him worry, and full explanations to the patient. Be sure that the patient understands the treatment plan. It means that you reach half of your way to treat that patient. Thank you very much.